In terms of the initial indications for treatment and selection of treatment, what do you guys think? Is this one of our usual historical dichotomies, was transplant eligible or not?
Sure. Well, that's always an interesting question, especially for a 74-year-old. And it used to be that people would say, okay, over 70 or over 65, they're definitely transplant ineligible. And we now know that's not true. Age is just a number. It doesn't necessarily correlate directly with functional status. And this person right now has an ECOG of 1, but that actually could even get better if they got therapy and they felt better and their anemia improved. They may become an ECOG of 0. Indications for treatment in this patient right now are anemia, but he probably needs a PET scan or at least a whole body CT non-contrast to see if there are other bony lesions that would explain some of the hypercalcemia, et cetera. So I think he'll make criteria, he does, for treatment. And after considering treatment, thinking about transplant, it would be based on his performance status, I think. And being 74 would not be the limitation. We were just talking about this, but I actually do offer transplant even to my older patients, even through 75, and I've actually gone higher. Sometimes what I'll need to do is decrease the melphalan dose from 200 to 140, but I found that they generally tolerate it well, and what it allows them to do is get a certain number of cycles of therapy and then get the transplant and proceed to maintenance, which we'll talk about later. But I think this person should be at least considered for transplant. Just because of age, he shouldn't be denied. He should definitely be referred to someone to make that decision.
Part of the evolving change in oncology to not just look at age, but really the overall, and we have the great frailty indices in myeloma as well.
Frailty, yes.
But you alluded to a few cycles, so let's say we're postponing the definitive decision for transplant. What would your preferred initial therapy be for this gentleman?
So I think there's data that you can potentially, using the Alcyone trial, consider if you were saying this person's transplant ineligible, you could give them Dara-VMP. Now, in the US, it's a little bit difficult to swallow because we rarely use VMP. And so for that reason, there might be some hesitation to do that. But you could consider giving a triplet regimen to this patient. And I would say 6 cycles, somewhere between 4 and 6, depending on tolerance. And you do really have a multitude of options. You could consider the RVD Lite, which was fairly successful in the data you produced. I think even Cyborg-D is reasonable, very well tolerated in this age group. And I don't know yet if we can really extend the DARA component from the VMP to the other triplets yet, and that remains to be seen.
Ola, what would you do?
Well, I think Nina kind of covered it all here, so try to add some nuances. I think because the patient is 74 years old, that, in my opinion, also does not preclude transplant as an option. But I think you could also take the other approach and say that with all the new drugs we have, you could actually drive down the disease very deeply, so maybe transplant doesn't have to be given. So putting those two pieces together from a practical point of view, if the patient is not really thinking of a transplant up front, is a 74-year-old patient really a patient that should think of delayed transplant? Probably not. So I think that's an important discussion to have. If transplant is going to be given, maybe now is the time. If it's not going to be given now, it's probably not any reason to think about collection of stem cells, because if the relapse comes at age 80, probably not going to transplant then. So I think that's an important discussion to have with the patient. I think I would think of RVD Lite. I think you went over that very carefully. That's a good option. I think Cyborg-D is another good option. There is quite limited detailed information in the literature comparing RVD versus Cyborg-D. There is a French study showing that the IMiD gives deeper responses, and that's the clinical gut feeling I have also. But now if you're thinking of RVD Lite, there's less of therapy compared to Cyborg-D, so that we don't know based on data. So I think they could both be considered, and if there's a little bit of a kidney failure, maybe you could argue pro Cyborg-D. So I think you have the Cyborg-D, you have the RVD Lite. I think they're both very valid options, but I think instead of just going lightly, you could also think of KOD. And I've treated a lot of patients, and I know you have too, with KOD. I just completed therapy on an 80-year-old patient in my clinic who got 8 cycles of KOD and reached MOD negativity, and that went very well. I've treated a lot of older patients with KOD, so that's a very powerful regimen. And I think you could say this is a 14-16 translocation. Why would you not offer this patient who is 74 years old, the best therapy you have. So I think you could make a case for any of these regimens, and I would have the discussion with the patient and go over the pros and cons and make the decision together with my patient.
So I think this is a great discussion for a 74-year-old patient with symptomatic myeloma. We have to establish clonality by blood and marrow testing, and luckily we have a lot of choices, and we don't necessarily have to make the final transplant decision when we first meet the patient. There's an important element of response and tolerance of other therapies. So it's good to have options, and so I think this was a great discussion.